Dear colleagues, welcome to our session on tailoring mitral valve repair, introducing MitraClip Generation 4. My name is Philipp Lurz, cardiologist from Leipzig, and I have the great pleasure and honor to moderate that session together with my co-moderator, Professor Hendrik Treede. He's the director of cardiac surgery at University Bonn. We also do have two excellent speakers and really experts in the field with us, Carmelo Grasso from University Catania and Fabien Praz from University Hospital in Bern. So the objective of that session is to learn about the MitraClip Gen 4, the latest innovation to treat mitral regurgitation by a transcatheter approach, and how to make the most out of the opportunity to tailor mitral valve repair to the huge variation of anatomies we are faced in our daily practice when treating patients with mitral regurgitation. We will have a lecture on the latest MitraClip Gen 4 technology by Carmelo Grasso. We then move on to a live in the box presentation and explanation how to make the most out of the MitraClip Gen 4 device with a panel discussion. We then continue and hear about the surgical perspective on why mitral repair requires tailoring, followed by another case presentation by Fabien Praz, and then a discussion at the end. We also have Fabien Praz with us, who will be the chat master, and you'll have the opportunity to direct questions, and please make the most out of that. So if there was one message to give to set up the scene for this symposium, then it is the message that the anatomy and pathology in patients presenting with severe mitral regurgitation varies a lot, and that requires a tailored therapeutic approach. The fact that anatomy varies a lot is not particularly new, but what's new is the fact that now with advancing technologies, we have the opportunity not to use one device to treat these huge variations in pathologies, but to adjust to the pathology we are faced with, having 4 different devices, device sizes, and make the most out of such a tailored approach. And the overall target of that symposium is to give some impressions on how to use these 4 devices in different anatomies. And without further ado, I'd like to ask Carmelo Grasso to give us the first lecture on the MitraClip Gen 4, evaluating the procedural tailoring. Please, Carmelo.
Thank you, Philip. Good afternoon to everybody. I'm going to talk about the MitraClip Gen 4 improvement and the preliminary data of these new devices. These are my conflicts of interest, and since in 2008 was made the first procedure with the first generation, the biggest improvement was made in 2018 with the introduction of the new sides, the extended side, the longest version called the XTR. And we have recently seen the data from the EXPAND study. Now in 2020, we have the Gen 4 MitraClip, so the latest generation with the addition of 2 more sides that are the wider clip. And which are the improvements? So we have now 4 clip options, so 4 clip sides, among which we can decide to use one size or another one. We have now the controlled grip actuation. That means that we can make an independent grasping or an independent adjustment of leaflet insertion. We have now the possibility to have a left atrial pressure continuum monitoring that may be very helpful during the procedure. And even the preparation of the device is much easier, so we can save some time. Here you can see that the wider version is 50% wider in the grasping area, and you can recognize it even at the angel. The length is always the same. In this swine-herd model, you can see that the provision is to have up to 63% reduction of MR because of a larger coaptation area if we compare the XT wide with the NT version or even with the XT version. And how we have to change our mind when we have to do a MitraClip procedure, because we have the possibility to tailor the procedure to different mitral valve anatomy. And we have to take into account length of leaflet as the first thing to understand if we can implant the XT version or the NT version. Then we have to see the width of the jet. So in case of broad jet, we can even use the wider version. And of course, we have to take into account the mitral valve area. The biggest, in the biggest area of, if we have the biggest area of valve, we can even implant the XT wide or the NT wide if the length of leaflet is not so much. So we have to understand how to manage the 4 different sides, but then we can tailor our procedure. Another big improvement is the independent grasping. So we have the possibility to raise, to drop down the grippers in an independent way. This is, in my opinion, this is not a thing to do routinely, but then we have to understand how to optimize the procedure, and then we can use it if we have if we are not sure of leaflet insertion. We can open the posterior or the anterior grippers, and then we can improve our results. As I told before, we have the preliminary data of the Expand G4 study. The primary objective is to report on core lab adjudicator 30-day real-world outcomes with the MitraClip G4 system. We enrolled 101 patients, and we have the result of 30 days. Baseline characteristics was similar to the Expand study, so there are no biggest difference. And this is an important one because this slide shows that in 61% was used just one clip. So a majority proportion of patients were treated with a single clip if we compare it with the 55% in the Expand study. As a first choice, when you use a single clip, in the 82% of patients, a wider clip version was used. When we implant the second clip, the first choice, 66% of patients, was the NT. Procedural outcomes were similar to the Expand with a very high implant rate, 99%, with a very high acute procedural success. That means that we have 2 plus or less mitral regurgitation that reached 99%, and we have even a relatively faster procedure. With the Echo Core Lab Adjudicator MR severity, we have an improvement of 30 days of patients with a very high proportion of patients with 1 plus or less mitral regurgitation that now reach 90.8%. It's a little bit more if compared with the data of the Expand. And even improvement in terms of NIA cluster or quality of life was higher if we compare it with the Expand result. About the adverse events, we have similar results of the with the Expand study. So we have just 2% of all-cause deaths, and both patients died for heart failure, and it was not related with the procedure. The patient was discharged at home with MR1 plus, and even the single leaflet device attachment was 2%. It was comparable to the Expand result. And this was due without an increase of the gradient. So the wider clips were not associated with an increase in mitral gradient post-procedure if we compare it with the third generation clip size. Of course, these are preliminary data. We have a small number of patients treated, but it seems to be very promising in terms of results. So the conclusion is that this is the first report on Gen 4 MitraClip, wider clips were used as the first choice in 87% of cases. And if we compare it with the third generation of MitraClip, we had similar procedural effectiveness, more patients treated with just clip, 61% versus 55%, and even a faster device time. And this was made without an increase in adverse event or in gradient. Thank you.
So thank you very much, Carmelo. That was a brilliant presentation, very thoughtful. We now move on to a case that was recorded in Leipzig by Philipp Lurz.
Hello and welcome everyone in our hybrid OR at Heart Center Leipzig for a MitraClip Gen4 implantation in a patient to treat mitral regurgitation. My name is Philipp Lurz and I have with me an interdisciplinary team living up the heart team approach, my dear friend and colleague Thilo Noah, cardiac surgeon, Christian Besler, cardiologist, and our fellow from Japan, Nobi Kitamura. We also have with us Jörg Ender, Director of Anesthesiology. He will look after the patient's GA, but also will do, and as you know, this is of utmost importance, he will guide us through the procedure during the TEE. I'd like to ask Christian to give us the details about the patient.
So, dear colleagues, the patient we are treating today is a 61-year-old male patient with a BMI of 25.9 kilogram per square meters. The patient has a profound cardiovascular risk factor profile with arterial hypertension, dyslipidemia, and he's a former smoker. The patient is known for ischemic cardiomyopathy with severely impaired left ventricular ejection fraction due to one-vessel coronary artery disease. The patient suffered a large anterior myocardial infarction in 2008 and experienced recurrent hospitalizations for decompensated heart failure within the last years. In 2016, the patient underwent CRTD implantation. The patient is further known for permanent atrial fibrillation, and in 2015 and 16, the patient experienced VTs and was successfully ablated. The patient currently presented to our hospital with stable dyspnea on exertion in functional class 2 with intermittent orthopnea and intermittent lightheadedness. For the laboratory investigations, the hemoglobin levels is well within the range, 9.1 millimole per liter. eGFR is about 60 mils per minute, and the NT-proBNP levels are about 2,200 nanograms per liter. The patient managed to walk 350 meters on a 6-minute walk test prior to the procedure, and at the termination of the test, he reported significant dyspnea. These are the TTE images obtained pre-procedural. You can clearly appreciate a severely dilated left ventricle with impaired left ventricular ejection fraction. You can anticipate the adverse left ventricular remodeling due to the large anterior myocardial infarction. In the past, both atria enlarged. Right ventricular function is reported to be about 17 millimeters when measured by TAPSE, and you can appreciate the mitral regurgitation, which we'll see in detail in a second. The SDS score for mortality for isolated mitral valve repair in this patient is about 2.2%, and the Euroscore 2 is 2.75%. And after careful discussion of this case in the heart team, including heart failure specialists, we decided to go for a transcatheter edge-to-edge repair of functional mitral regurgitation in this patient instead of a mechanical assist device or heart transplantation evaluation, given the stable clinical condition of the patient, with the aims to improve the symptoms in this patient, to improve quality of life, to stabilize kidney function, and possibly to further escalate the medical heart failure therapy in this patient.
We then would like to ask Jörg Ender to show us the live images from TEE, please.
Yes, so hello also from my side. Here you see normally the 4-chamber view and the explain corresponding 2-chamber view, and as you can see here, That patient is, from an echocardiographer point of view, a nightmare patient, because the left atrium is really very small, and you know that the left atrium acts as an acoustic window for us for the mitral valve. But we can confirm, of course, the huge left ventricle with poor ejection fraction. You see, you cannot really have good standard views. So what we see here is the long axis, and you see it's nearly really horizontal, where you see a PML which is 1.2 centimeter length, and an AML, you see the severe tethering, of course, due to the poor left ventricular function. We have a central mitral regurg with a little bit eccentric over the posterior mitral leaflet, with a vena contracta of 7 millimeters, and here you see the mitral commissure, more or less, with a coaptation defect all along the coaptation line, again on the long axis. And these are patients where I think 3D helps a lot. So with multiple planar reconstruction, we were able to calculate the 3D vena contracta area, which is, as you can see it here, 0.6 square centimeters, which is a really severe mitral regurgitation. And you see it here from the 3D that the regurgitation goes all along the coaptation line.
Thank you very much. So now we need a discussion about how to treat that anatomy and which device to choose. We have now 4 different clip sizes and configurations. What are your thoughts?
I would like to move on with some words or remarks about the strategy, about the treatment strategy. I would like to sum up that we have a really challenging case due to the fact that we have a functional mitral regurgitation with a severely enlargement of the mitral annulus. The mitral annulus was calculated in anterior-posterior direction with 40 millimeters, and we have also a corresponding dilatation of the mitral annulus in lateral medial direction. The second point is that we have a regurgitation area which ranges from the segment 1 to segment 3 of the mitral valve, and the third key problem are the difficult imaging condition. And I believe in that case we should start with the larger version of the Gen 4 MitraClip. That means we would like to use the XTW to place the first clip in the middle of the valve and to see how is the result after the first implantation, and then to decide if we need a second device or if it was possible to create a large coaptation area to reduce the mitral regurgitation.
Couldn't agree more. Choosing the largest device to get the biggest tissue bridge, and thereby hopefully implant only one device given the challenging anatomy and the rather unusual imaging. So what we've done so far, obviously we've gained femoral venous access. We did a transeptal puncture as posterior as possible. We positioned the guide in the left atrium. We also have simultaneous pressure tracings, and as you can see, there is a significant V wave indicative of severe mitral regurgitation. We've chosen the XTW clip, and we explained why, and we're going to start now to introduce that and implant it. Okay, the clip is leaving the guide, and we watch on fluoro and echo to make sure that we do not interact with any left atrial structures. I think we're in the right direction towards the pulmonary vein, just advancing the handle at the back to make sure that we're on the right track. And then we can fully straddle, which we've done now. And the next step is then to steer down to the mitral valve, introducing some flex by turning the M knob. Okay, now we'll see how how we get along with modified imaging planes for the reasons discussed before. We have the clip on top of the mitral valve. We are pretty much perpendicular in the commissural view on the left and on the modified long axis view on the right. And now it's time to open the clip. Okay, the clocking seems not to be okay. So first of all, we correct the clocking of the device on a 3D image, please.
Yes.
Okay. Now it seems that we are sort of 6 o'clock, 12 o'clock, 90 degrees to the line of coaptation. Okay, that seems to be okay. What we do next is we certify the specific feature of that Gen 4 MitraClip, which is the ability to do independent grasping.
If we turn the blue knob in the other direction, we have the possibility for an independent leaflet grasping. And if we look at the echo images, then we are checking now these function. And in this case, you can see that we are moving the gripper from the posterior side, and the other one is from the anterior side.
Okay, perfect, very good. The initial approach here is, as always, to do simultaneous grasping, but make the most out of that feature if necessary. And we also have to remember which one was which, but we should be able to do so. Okay, I think we're pretty much ready. What we normally do is we ask for a breath hold, and then we cross the valve, and we close the device slightly, just to make sure that we are not getting entangled anywhere. And as you can see, there are quite a lot of cords there. Okay, so we do have a breath hold now?
Yes, we are.
Okay. Then we cross the valve. We check on fluoro, the trajectory, and the clocking. And then we'll take our time to get the modified imaging planes.
I'll try my best.
Sehr weit posterior. Und ein bisschen medial.
I would just turn from there.
Okay, now you can see that we are pretty much in the central position within the valve. Can we see some color, please?
Yes.
Okay, that seems to be right. We open the clip a little bit more, and then we will do another 3D just to make sure that we have the perfect clocking before we do our first grasping attempt. Okay, so we're slightly off. Oh. Are we?
A little bit anti-clockwise, I would say. Yeah.
Okay, like this.
Yes.
Perfect. Okay. Now we come back and try to get both the anterior and posterior leaflet engaged on the device. The anterior is on, the posterior is rolling a little bit. Let's see what happens if we come back a little bit more. But it seems that the trajectory is not ideal there. Go into the ventricle again to allow the device getting underneath the posterior leaflet. It's still rolling. Okay, in again. Okay, anterior is on. Posterior, can we try to change the imagings ever so slightly?
Like this?
Okay. Now also I think we moved a little bit medially, so we correct for that. Take off some M. Are we still good with breathing?
Yeah, saturation is a little bit decreasing, but it's fine.
Okay. I think we have to change the trajectory in there a little bit to make it better. We do have another breath hold now. We see that we have a slight trajectory on the right towards the anterior leaflet. We corrected for that by introducing some minus on the guide. Now we're trying to, again, come back into the valve and get both leaflets on. The anterior is easier. Posterior, we'll see whether we'll manage now. Okay, now I think we are good. Shall we do another 3D?
I will do.
Just because it's more difficult to see here whether we are right in the center of the valve, and also to check the orientation.
So aortic valve is over there.
Okay, good. I think that's an okay position.
Yeah, posterior is on.
Okay, so we bring down the cripper together, down, and then we close carefully and slowly. But now we have nice images and everything under control. You see there is some tension on the leaflets, indicating that they're nicely in. Close that in full. All right, that's it. And then breathing on. Now we have some time to assess what we've achieved.
That looks
Not too
good.
bad, first impression.
I agree. So we try to get.
Okay, that's a nice
leaflet insertion is really excellent.
nice all-fast view of the valve. Good tissue bridge, double orifice. I think both leaflets are going nicely in and out of the device. Can we have some color on that, please?
Yes.
Okay, that's good.
It's not too bad. At least in that view, only really very mild or even trace MR. We will go for 3D again. Add color. So that is nice. You see only medial, a really small jet.
Very good.
Try to get midesophageal images as good as possible. But as I said, that's my nightmare.
Tilo, what do you think?
I think it is an excellent result for these difficult imaging conditions, and also the difficult anatomy. We have a rotation of the heart axis, which leads to an increase of the, how we can say, it's a difficult case, and for that I'm absolutely happy with that results.
It seems like it was the right decision to use the longest device with a larger width, the XTW, to get a tissue bridge as large as possible, but implant only one device, because the first one was okay, but then implanting a second next to this one with these imaging conditions, it is possible, but it's not the most comfortable thing to do. All right, so we will double check for gradient, again color, and I think we are ready to release.
Bad signal. That would be mean pressure
that's
of
good.
2.
Now starts the part which is completely different to the Gen 3 generation of MitraClip. At first we are pulling out the blue pin, and therefore we have to turn the pin 8 times counterclockwise. 1, 2, 3, 4, 5, 6, 7, 8. And then we're pulling out under fluoroscopic control. And the last step is to pull out the gripper line. And now you can see very nicely that the clip is completely released from the delivery system.
And the gripper line now is within the system, but does not have to be pulled out in total as it was before. Okay, so we remove the remove the device and do our final and last assessment.
So now you see it's even maybe a little bit better than it was before. You see really very, very tiny jet on the medial side. And a trace MR, I would say. It's not worth to measure.
Yeah, it's an excellent result for that patient, and hopefully it improves the symptoms and also the clinical perspective of the patient.
When the surgeon says it's excellent, then normally it is excellent. That's good. And in practical terms, what it means, we've implanted 1 device rather than 2, as we did before. And the fact that comes handy is obvious. Okay, I think we are done. Maybe at the end, also another confirmation and appreciation of the pressure tracings of the left atrium. We don't have significant V wave anymore. We brought down the mean LA pressure from 35 down to 20, and that confirms what we've seen on echo. So in conclusion, we had a patient with a severely reduced left ventricular ejection fraction and functional mitral regurgitation. We were confronted with a very broad regurgitant jet extending from the medial towards the lateral commissure. We had some difficulties with imaging, which required us to use slightly modified imaging planes. We used the XTW device. The idea was to create a tissue bridge as large as possible, hoping that we can get away with only 1 device and thereby reducing MR significantly. I think we succeeded so, and overall we did a procedure in a reasonable amount of time in a challenging anatomy, achieving a very good result. Thank you very much for your interest, and thank you to the whole team. Great pleasure for having us. Thank you.
Wow, Philipp, that was really a great case. I mean, that was challenging. The kind of anatomy, very bad ventricular function, very bad imaging due to the heart axis. So this is really very impressive that with just a 1-clip strategy, you could achieve such a great result. So if you compare now Gen 4 with what you had before, Gen 3, you already mentioned that you would have definitely have used like 2 clips beforehand. When it comes to gradients, you now ended up with a very good gradient of just 5. Would you, with the 2nd clip strategy, have feared that there might be a higher gradient afterwards in the former times?
The possibility to have a higher gradient when using 2 devices. I think in this case the XTW was just a perfect combination of creating a tissue bridge which is large enough to reduce MR to trace, but at the same time allow enough opening to get away with acceptable gradients. Obviously, this is 1 patient, and you can't repeat the procedure with a different approach. So you never know. But from our experience, I would have thought that we would have needed 2 devices if using the Gen 3 clip sizes.
You know, Philipp, I absolutely agree with your comment. I think when looking at the echo images from the beginning, which were, you know, a kind of special anatomy because probably of the size of the left ventricle as well, you would have expected to have needed 2 devices. So, you know, that's probably one of the features you have with the Gen 4. By the wider clip, you are able to reduce more mitral regurgitation. About the indication for that patient, you know, we have seen now very recently some data showing that in this patient, there may be a benefit, a symptomatic benefit and that you are also able to gain a little bit of time before transplantation, also in quite young patients that have been published. Is that your experience as well? Do you have some experience with this kind of patient?
Absolutely. I think that two things are important. First, if you have these patients with severely reduced left ventricular ejection fraction, I think it's wise to discuss them up front with your heart failure specialist, so everyone is on the same page here. And make sure after the procedure that you still keep him in close follow-up. But if you do so, then the risk of missing the right point to consider a assist device, the risk is very low. And in between, in our experience, these patients, they're much better off, they're less symptomatic, and also they gain a couple of months or years before they then are reconsidered for an assist device, which obviously can be very beneficial for these patients.
And Carmelo, when it comes to LA pressure measurements, it has become an important feature now with MitraClip implantations. If you look at this special kind of patients at severe heart failure, what is the role of LA pressure measurement in these kind of patients in your mind?
Yes, this is a good feature because you can have a continued measuring of LA pressure, and it is very important to match the pressure with the color and with the results. So when we evaluate the results on a mitral procedure, we have to take into account all this feature. So sometimes we see some patients with big final color but low LA pressure, and opposite. Sometimes we still see patients with trace MR but high LA pressure. So this is a combination between left ventricle sides, left atrial sides, and we have to take into account each parameter we have to decide if our procedure was good or not. So this feature is very important. It may help us to have a better result at the end.
Mm-hmm.
Philipp, one more curiosity that may be of interest also for the people looking at this program, that you are, if I'm not mistaken, you are doing your grasp in Grasso. Is that correct?
Yes, we do.
So that's something that probably not everybody is doing. So what we do typically at our center, we just reduce the tidal volume, the breathing volume of the patient to minimize the movement of the chest and of the heart. But you do that with Grasso. So what is the advantage of that technique?
Well, I think if you prep the patient well, then you can easily get away with 3 minutes of breath holds in our experience. But normally you need even less, and you have the situation of very stable conditions with the clip not moving at all in medial lateral direction, and that can be tremendously helpful, especially in difficult anatomies, and facilitates the attempt to place the clip exactly where you want to. And that's why that's our general approach these days. We always do it during breath holds, even in less complex anatomies. I find it really helpful.
So yeah, thanks, Philipp. So obviously tailoring is an important part of surgery with every mitral valve repair we do. And it's great to see that we now have the same opportunity with the MitraClip Gen 4. So we all know, of course, that MitraClip surgery is complex, and so is mitral valve intervention. We've just seen a very complex case, basically. And this is due to the fact that we deal with different etiologies of MR. We deal with degenerative MR and functional MR, and as a surgeon, you would have special approaches to both kind of diseases. So for the degenerative, you very basically do an neuropathy and combine it with artificial cords, so that even cleft closure if needed, leaflet augmentation, resections if needed, even edge-to-edge repair, especially in the commissural parts. So there are various techniques that are done in combination. And for the FMR patients, there's also additional techniques you can use. You can do the ring alone if possible, but very often you have to combine it with some kind of subvalvular repair regarding the papillary muscles that are being approximated or sutured against the annulus, or various other techniques that need to be done to make these valves closing again. And very often you use a ring. I would say like in 99% of cases you have to use a ring. And even when it comes to rings, you have a bright choice of rings. So As a surgeon, you always tailor your repair strategy to the specific patient anatomy. And here you see how we do it. Actually, should be done minimally invasively. This should be the standard today. We do these things endoscopically and have then various techniques being applied to the valve, as you can see on these images. I don't want to go into detail here because we're speaking about the MitraClip and not about surgery. But when you tailor the mitral valve repair and surgery, why shouldn't you do it the same way, basically, in interventional mitral valve repair? And this can now be done. And we heard the great talk already of Carmelo, and he was speaking about the fourth generation of the MitraClip with the 4 clips that are being available. But what I'd like to share with you is the data on the last generation when we had 2 clips available. At the time, this was a big step forward already, and it was also combined with an improvement in the catheter technology, so the clips could be better deployed and steered. And then there was a really big data collection in this regard with the EXPAND study. There was a prospective multi-center trial in more than 1,000 consecutive patients receiving the NTR and XTR clip generation at 60 sites. With a 1-year follow-up, and it was also adjudicated by an independent screening committee and a core lab. So the data is very reliable, and it's quite amazing to see, actually. So of those 1,000 patients who went into that study, we had an 84% overall follow-up at 1 year. And I don't want to bother you with this slide. You don't have to read the numbers, but just to make you clear again that there's a difference between primary and secondary MR when it comes to patient demographics. So of course, the patients with secondary MR within that study have been at much higher risk, have had more comorbidities like renal failure, diabetes, dyslipidemia, and everything. They have been very more often in hospital than the primary MR patients. But this, of course, was to be expected. And you see it was a typical high-risk patient population treated with the clip at the time. And here you can see how the clips were used, actually. So about 45% of patients received the XTR clip only, about 40% the NTR clip. But there's also been a portion of patients with about 15% who got both clips in one patient. So you can again see that there was kind of tailoring with using the clips in the specific anatomies. And if you then compare the EXPAND data at the time with the available data of other trials like the Everest and the TVT registry and the ACCESS-EU, then you've seen that with using the 2 clips and having the availability of the 2 clips, you could achieve much better implant rates, much better procedure success rates, you have much shorter device time, fluoroscopy time, and procedure time. And Carmelo was just showing up that the same number compared now with the Gen 4 were even getting better with the next generation. So this was the first step in the right direction. And if you look at the effectiveness, it was quite amazing to see that there was a very high reduction of MR that could be achieved with these 2 clip designs. And after 1 year, already 89% of patients, this is really quite astounding, had less than 1+ MR, and very many had actually MR, and only a small proportion had less than 2+ MR, and only 0.5% of patients at all had more than 2+ MR, what is really very good for a MitraClip population. And this also paid off because patients showed much better quality of life, and also, again, as compared to other studies, the biggest improvement in quality of life with more than 21 points in the KCCQ assessment score. And this could also be seen in the New York Heart Association class, so patients took also clinical benefit from having the clips implanted, with a very stable and controlled, stable New York Heart Association class 1 or 2 of 80% of patients after procedure. This again paid off in terms of hospitalization rates that came down by 63% when you compared the first year before the clip implantation with the first year after the clip implantation. So patients really could stay at home much longer. And it was also seen in echo data showing a significant reduction in left ventricular dimensions of about 20 milliliters and diastolic volumes, and about 10 milliliters in the systolic volumes. So also the echo data went in the same direction. And then, and this is really very nice to see, it also showed a great impact on all-cause mortality. If you compare the EXPAND data with the other registry data and the average trial data at the time, now the early 30-day mortality is just 2.3%, and the one-year mortality and this very sick patient population, you've seen the demographics on the one of the first slides, only 14.9%. So with a better result in terms of reduction of MR, you can also achieve a better postoperative survival. So if we now sum this up, the EXPAND study was the largest contemporary world study of the MitraClip NTR and XTR at the time, before Gen 4. And already with these two clips, we could show there was the highest MR reduction achieved with that device compared to the studies beforehand. The largest one-year improvement in quality of life, the highest reduction in heart failure hospitalization rates, consistent reduction in LV dimensions, and the lowest 30-day and one-year mortality reported so far in a large-scale real-world registry. So really good data already at the time, and thereby it could be demonstrated that having additional clip sizes available helped to tailor the therapy to patients' individual mitral valve anatomy, and thereby allowing to successfully treat quite a broad range of mitral valve patients. And with this, thank you very much.
Dear Hendrik, thank you very much for this excellent presentation and for the summary of these very encouraging results. If I may just make one comment, and this is about the necessity to do annuloplasty. You made the point, and we've heard that, and we've seen it in many studies, that for surgical mitral valve repair, the annuloplasty is very important. And some people always raise the question, how can we be successful? How can we be successful with MitraClip and a pure edge-to-edge therapy without doing annuloplasty? And I think it is important to realize that it's not just an edge-to-edge therapy, but you also get an indirect annuloplasty for free. And this range is about 15%. So when you do edge-to-edge therapy using the MitraClip and you do it right, then you get a 15% of annular dimensions reduction.
Yeah, that's right. We had that discussion from the very early days of MitraClip on, but the data has significantly proven this, what you said, that due to the high coaptation length also that you can achieve with the clip coaptation, there's kind of a scar formation along A2, P2 or wherever you do it, and this somehow fixes the annulus and reduces it down to a size, as you said, reduction by 15%. So that works.
Good. Okay, then we move on with another case presentation by Fabien Praz. Please, Fabien.
Thank you very much, Philipp. Thank you for the introduction and for the opportunity. So maybe let's look now at a case we treat very recently, actually, here in Bern with the Gen 4 device. So yeah, my conflict of interest. So that's our patient. So it's a 77-year-old patient. He's a smoker, an active smoker. He has a chronic obstructive pulmonary disease, so you can see quite a lot of comorbidities. He has been also pre-operated in the chest because of a carcinoid tumor that had been treated several years ago by surgical lobectomy. So he has, as you see, quite a diseased lung, and that was also the reason because this quite young patient has been selected for a transcatheter therapy. He also has an arteriopathy and has been treated in 2015 due to this. So we have discussed this patient in our heart team as he presented with worsening dyspnea, NYHA class 3, and cardiac decompensation. He has a normal left ventricular function. He had a coronary angiogram some years ago, 2 years ago actually, with normal coronary artery, so we did not repeat that procedure. And what has been seen actually on the right heart catheterization was a severe pulmonary hypertension, mean pulmonary pressure of 42 millimeter of mercury, and a V wave. But the reason for that was not completely clear. There was no tricuspid regurgitation, and what the diagnosis was actually made by a transesophageal echocardiography. And what you can see is a very eccentric mitral regurgitation. We will see exactly the etiology on more images in a minute, but this is a kind of mitral regurgitation that can be really missed or underestimated on transthoracic echo. So very eccentric jet, and you will see the relevance of this mitral regurgitation in 1 minute. So that's our Treede evaluation, something, of course, that is needed in a routine way to be able, to assess the lesion, to see where is regurgitation located, and what are the options to treat this patient. What you can see here is a primary mitral regurgitation with a very eccentric jet toward the posterior leaflet. And the reason for that was a commissural prolapse. There is also a bit of an indentation at the commissure, at the medial commissure. And we actually assume here an A3, P3 prolapse in the commissural region. So quite not a very easy anatomy for a transcatheter treatment. So again, we saw this already with Carmelo. So we look at our selection graph for the Gen4, and as you know, we have now 4 different sizes. So what we look at is the length of the leaflet, and it was in that case more than 9 millimeter. The width of the jet was quite a wide jet, I have to say. Localization was commissural. It's not in the direct selection criteria, but I think it plays a role as well. And the mitral valve area that was above 4 square centimeters, so the patient was certainly suitable for a clip procedure. So looking at all these factors, good mitral valve area, wide jet, and good length of the leaflet, we decided to go for an NTV, which is the larger size of the NT clip with Gen4. So what we did a standard transeptal puncture and high posterior position, and then we went first, as a first strategy for the first gap, with simultaneous gripper actuation, meaning that we just do it in a usual way, having, as you can see here on the echo images, having the both leaflet on the arm of the clip, then dropping the gripper in order to secure the leaflet, and then we closed the clip. And that was the first result. That was the first result after the first grasp. And what you can appreciate here, we have our medial position in close to the medial commissure, but we still have a component of that jet that is quite eccentric and going along of the posterior wall of the mitral valve. So what we decided to do, instead of repositioning the clip in that situation, we decided to go for an optimization technique of the grasping, because you can maybe appreciate that the posterior leaflet was still prolapsing a bit, and that we didn't have the full control of the leaflet with the first grasp. So that's exactly what we did. So what you can see here is an independent gripper actuation for optimization, and what has been done, you see the red arrow, is that the gripper has been opened, so the clip has been opened first, and then we open the gripper on the posterior side, with now the posterior leaflet free, moving freely. And at the same time, the anterior leaflet is still captured with the gripper down. So we are now able to optimize the grasping of the posterior leaflet only, keeping the anterior leaflet still captured and secure by the gripper. And this, you do it by a very gentle movement of the clip toward the posterior leaflet, toward the posterior annulus, ensuring that we will not put tension on the anterior leaflet. That in that situation is quite long, so that this danger or this risk was low in that particular patient. And this is possible thanks to the independent gripper actuation. So this lever, this new lever, enabled you, when unlocked, to control the grippers in an independent way and to move up and down only one of the gripper in order to be able to optimize. Another technique that you can use also is an complete independent grasping. And in that situation, you will grasp one of the leaflets first, move the steerable catheter toward the leaflet you want to grasp as a second leaflet, and then close the clip, a technique that we did not use in that particular case. You can see it here again. So you close one of the gripper, move towards the other leaflet, close the second gripper, and then close the clip. In that movement, you have to be very careful not to turn the device during that time to avoid having a distortion of the valve. So that's the strategy: simultaneous grasping first, what we did, then the ability to control leaflet insertion by reopening the clip and controlling one of the leaflet after the other. If leaflet insertion is adequate, you reclose the clip. If not, you optimize. And if both these techniques are not working, then you will go for an independent, completely independent leaflet grasping as a third option. So that's the final result. You can see a mild mitral regurgitation. This complete eccentric jet is gone after reoptimization. We didn't move the clip in that situation, but just did an optimization of the grasping of the posterior leaflet. Mean gradient was 2, and we closed the case with a good result. So in summary, what we are witnessing is this technical evolution with growing operator and center experience, and this translates, as it has been mentioned already, in a better result for our patient, in a higher rate of patient with MR grade 1 or 0 at the end of the procedure, but also in a lower SLDA overall over the history of the development of the edge-to-edge therapy. Thank you very much.
So now we are live with you for a quick discussion of what you've just seen. And I would like to ask Carmelo an important question. I believe we have much more options now, but we also have more decisions to make. Carmelo, you do have some experience or sound experience already with the Generation 4 device. What would you consider as your preferred choice of clip when treating functional regurg?
Thank you for the question, Philipp. Yes, I already used the G4 version, and in my opinion, the first choice in the functional MR will be the anti-wide clip. And then we can decide if we need other wide clip, if we have enough space, or if we can go with the older version, with a not wide, with the normal version. So, but I think that this will be the workhorse clip in the future.
And maybe a quick comment about how do you decide when to use the NTW and the XTW in functional MR?
Well, basically you have to see at the length of leaflets. If you have the posterior length that is enough, you can even use the XT, but remember not to do excessive tension. So release a little bit of tension when closing the XT to avoid injury of the leaflet. This will be really important.
Thank you. Absolutely. And then a quick question to Hendrik. From a surgical point of view, what's the fundamental difference between what we do with the MitraClip as compared to the Alfieri stitch?
Well, I think you cannot compare the two because the MitraClip has a much higher coaptation area to cover, and it also forms, a scar-like formation that leads also to an A2P2 approximation, and this you cannot achieve with a single suture in surgery. So I don't think you can really compare the two techniques. Just the same idea behind it.
Which is important because many do, and they also like to compare the results of these two techniques. And then I would like to hand over to you to wrap up this session, please.
Yeah, thank you, Philipp. I think it was a very educative session. To wrap it up, I would like to start with you said in the very beginning, every patient's mitral valve is unique, and we have to have tailored treatment to achieve the optimal possible outcomes. And we did this in surgery for a long time now with the Gen 4 MitraClip. We're also able in doing it in transcatheter mitral valve repair with the clips. And we have these new features with the clips, the additional wider clips to achieve a better coaptation area. We have the controlled gripper action. We have the continuous LA pressure monitoring, what's very important. And with the data from the EXPAND studies, we've seen that this really leads to an improvement in outcome. And I think this is a great achievement and helps us a lot for the future in treating patients with MitraClip. With that, I'd like to thank you all and have a nice evening and enjoy the PCR valve course.